The floor, please go ahead.
The question goes thus. A 25-year-old lady presented with severe recurrent hemicranial throbbing headaches for 7 years with associated photophobia and phonophobia. No nausea or vomiting, no neck stiffness or paralyzing sign. She normally takes NSAID with relief. However, symptoms episode last more than 30 hours without treatment. One, what is the most likely diagnosis? Two, what are the diagnosis criteria for the disease? Three, what features support the diagnosis? And four, mention 5 classes of medication that can be used for prevention. So number one, the most likely diagnosis will be migraine headaches. Two, according to the International Classification of Headache Disorder, third edition, you have criteria to fulfill. And A, patient must have at least 5 attacks fulfilling criteria B to D. Then B, the headaches must last 47 hours. C, headaches must have at least two of the following 4 characteristics. One, unilateral location. B, pulsating quality. C, moderate or severe pain intensity. D, aggravated by or causing avoidance of routine physical activity. And then the D part, patient during headaches, patient must have at least one of the following. One, nausea and or vomiting. Then B, photophobia and phonophobia. Then E, the headaches not better accounted for by any other headaches according to the ICHD-3 diagnosis. Now, in this, the third question says, what's in this question makes migraine the likely diagnosis. So once she's female, as we will see, it's commoner in females. Then they said it's recurrent. She's had it for 7 years. They didn't say how many times she's had it, but we can assume that she had it for more than 7 times, more than 5 times in those 7 years. Then throbbing, another word for throbbing will be pulsating. Unilateral, they said it's hemicranial, so it's unilateral as we'll see. Then associated photophobia and phonophobia, she had that. And that symptom lasted for 30 hours without treatment. According to the criteria, it must be from 4 to 76 hours. So she meets the criteria for migraine headaches. Then prophylaxis that can be used, classes of drugs that can be used for prophylaxis. You have antidepressants, the amitriptyline is commonly used. Then you have venlafaxine. Antihypertensives can be used, beta blocker. Most common of these would be propranolol. Others can be used like atenolol. Then you have the calcium channel blocker, verapamil can be used. AC inhibitors like lisinopril has been used. ARB, candacetan can be used. You have antiepileptic drugs, sodium valproate or pyramids. Then you have calcitonin, gene receptor, peptide pathway targeted treatments, erenumab, and then rimegepant has been used. Rarely you can use the N-methyl D-aspartate antagonist like memantine. Then some triptans have been used for prophylaxis. And lastly, you have the botulinum toxin can be used as prophylaxis. As a brief overview, what is migraine? Migraine is a primary headache. It's the second most common primary headache, second only to tension type headaches. And the commonest cause of primary headaches necessitating presentations to the emergency room as well as the outpatient department. Global prevalence about 1.1 billion worldwide. And they have a females male preponderance about 3 to 1. You have females more affected than females from all studies. Peak incidence is about 35 to 38 years, and then there might be a family history in some patients with the migraine headaches. The pathophysiology of migraine, I'll use this diagram. I hope you can see my diagram. I'll use this diagram to explain. Please, can you see my cursor? So the issue with migraine usually is there's impairment in central processing of pain for these patients. And usually you have impulses, you have sensory peripheral efferents from the head and the neck. The head, you have the V1 and the V2 branches of the trigeminal nerves. And from the neck, you have the upper cervical spinal nerves, the C1 and C2. They converge with vessels from the intracranial vessels, the meningeal vessels. And they congregate here and they pass through the trigeminal ganglion. On getting to trigeminal ganglion, they go to the brainstem where you have the trigeminocervical complex, the TCC. These are deemed to be first order fibers. These then send fibers to the thalamus. The thalamus is said to be to have second order fibers. Now, as we know, the thalamus is a sensory relay center. And what it does is that it sends fibers to different areas of the brain, including the prefrontal cortex, the hypothalamus, the locus coeruleus, the medulla, and the pons, amongst other structures. Now, when these fibers are activated, the patient will now have symptoms of migraine, simply put. So, for instance, the patient has the fibers in the cerebral cortex, in the prefrontal cortex, if they are activated. Now, we know the prefrontal cortex observes things like cognition. If these fibers are activated, patient can have cognitive impairment, for instance, or can have mood disorders. The fibers in the thalamus themselves, for instance, if they are activated, the patient will have impairment of pain perception. Patient can have anhedonia. And then if it's at the hypothalamus, patient can have this sleep-wake cycle pattern is also altered, and so on and so forth. So depending on the area of the brain that's like where the fibers are activated, the patient will come down with symptoms attributable to migraines. Now, I'm not in this diagram, but also fibers are sent to the dura mater. And when these fibers are activated, then you have elaboration of neurotransmitters. The ones that are commonly have been studied are the calcitonin gene receptor peptide. You also have the PACAP. Others are the serotonin, the dopamine, and the norepinephrine. It's important to know that when we are managing patients for migraines, these neurotransmitters that are targeted. We aim to inhibit these neurotransmitters to the patient's respite from the symptoms the patients have. And the four phases of migraine, you have the prodrome or the premonitory phase, you have the aura, you have the headache itself, and then the postdrome. It's important to know that not all patients will have aura. Just about 30% of patients will have aura, but these are stated to be the classical migraines. Now, the postdrome can occur anytime from 3 hours to about 48 hours preceding the headaches. If the patient doesn't have headaches, the patient might be irritable, can have cognitive impairment, all of that, depending on the area of the fiber in the brain that is activated. Then you have, this is followed by aura in patients that have aura. This occurs 5 to 16 minutes, about 5 to 60 minutes preceding the headaches. Now, what is known that the aura can happen concurrently with the headaches. Then you go ahead, then the headache occurs, which lasts for 4 to 72 hours, as you can see from the criteria. And then you have the postdrome or the migraine hangover that lasts for about 1 to 2 hours following the migraine. And patient can have cognitive impairment and still be irritable after the migraine itself has ended. So aura, like I said, only about 30% of patients will have migraines. And the typical ones are the visual, language, and the sensory. Visual being the most common. The atypical ones are the motor, auras, and then the brainstem migraine, brainstem aura. To make a diagnosis of migraine, migraine usually is a clinical diagnosis. What you will need to make a diagnosis usually is a good history. Once you take a good history, many times you can make a diagnosis of migraine. Investigations are usually not necessary except you think they are red flags. But usually, having done a good history, taking a good history, a diagnosis of migraine can be made. Managing the patient with migraine, there are two phases. If acute symptomatic or abortive, then you have preventive and prophylactic. Now, for an ideal abortive therapy, should give the patient rapid relief and complete resolution of symptoms as soon as possible. It should be single dosing. You really don't want to repeat dosing for patients with migraine if you can. Then patient will be able to return to function as soon as possible. The drug should have minimal side effect, and then it should be cost effective and available. To optimize acute treatment, you want to tell the patient to start the treatment early. Some people have said that once there's a premonitive symptom, patient can go ahead and commence medication. They want to give the maximum dose. You should consider non-oral, especially for patients that have nausea and vomiting. And then combination therapy can be considered. You want to treat the nausea, as we found that patients that have nausea accompanying their migraine usually have worse disability. The classes of abortive treatments include non-specific and then the specific and neuromodulation. But the non-specific, at best, the effect is said to be low or medium, but except for NSAIDs that have high effects. So you have the NSAIDs, the high V magnesium opioids, you have the ergot, and then the paracetamol can be used. Then it should be noted that this works for patients that actually have mild symptoms. When patients have very high disabling symptoms, usually this will not suffice for them. Then you have the migraine-specific treatment. The backbone for migraine treatment is triptan, as we know. But however, it should be used in caution with patients that have coronary artery disease, peripheral vascular disease, because it causes vasoconstriction. In instances like that, you can use DTAN. DTAN is serotonin 1F antagonist specific. And for these patients, it doesn't cause vasoconstriction while it's effective for the migraine. Others that can be used will be dihydroergotamine spray. It should be used with caution in patients because long-term use causes retroperitoneal fibrosis. So you want to use this only for rescue treatments for patients that do not respond to the triptans. Then you have the GPANs, the CGRP antagonist. Other abortive treatments, though not available now in our climate, but it's body of notes are the neuromodulation. And what it aims to do is that it sends electrical or magnetic impulses to the skin with the aim of altering pain perception and processing. The emergency management of patients with migraines, patients that come to the ER, emergency room with migraines, most of them antiemetics. Many times they are very weak and they have vomited a lot. They want to rehydrate them. Drugs that can be used would include subcutaneous sumatriptan. It's found to have its onset of action is faster than oral. Then you have the nasal dihydroergotamine. I've explained to you why you should use only for respiratory therapy. Others that can be used indomethacin, dexamethasone, ketorolac, and then we can do nerve block with lidocaine. Not all patients that have migraine would qualify for prophylactic therapy. Indication for migraine prevention therapy will include patients will have two or more severe or disabling migraine attacks per month. Or a patient that has 4 less disabling attacks per month, you want to consider starting the patient on preventive therapy. Then patients in whom acute therapy is no longer is ineffective or contraindicated. You want to start them on preventive therapy. The medication overuse headache when present. Highly disabling migraine attack, even if it's one, you want to commence your patient. If it's highly disabling, you want to commence your patient on prophylactic treatment. And then at times, patient's preference. Classes of drugs can be used has been answered previously, so please refer to that. The differential diagnosis, you have cluster headaches, usually proximal hemicrania, because it is hemicrania, like as in migraine. But it's important to note that this is side locked. So if a patient has cluster headaches, usually if it occurs on the left, it would always occur on the left. While in migraine, it's all side locked. Patient can have on the left one episode and then maybe the next episode is switches to the right. And then hemicrania, the proximal hemicrania doesn't last as long as the migraines. Usually is about 15 to 180 minutes. We have Meniere's disease, as in patients that have brainstem migraines or migraine with brainstem, or it can be thought to be Meniere's disease. And in conclusion, migraine is the second most common primary headaches, though not life-threatening. It's a major cause of disability worldwide. Aim of treatment is to reduce disability and optimize functional outcome of the patient. Thank you.
Oh, thank you so much, Dr. Malo, for that beautiful presentation. Okay, so now we'll take comments and questions from the participants first, and then our teachers will come in. And let's keep the thanks coming on the chat. So please, you can go to the question. Okay, so there are some thanks on the chat for you.
The water should be smaller.
Dr. Fechikan is saying thank you. Dr. Just is saying thank you so much for the presentation. Dr. Thomas saying thank you, Chief. How do you differentiate migraine from cluster and tension headaches? And others are giving you sending applause to you. Well done, Dr. Moye. Okay, do you want to comment on that?
To differentiate cluster headache, like I said earlier, it's more short-lived than the migraine. Migraine is usually, like the criteria says, 4 to 72 hours one. Then cluster, on the other hand, usually would be between 15 to 180 minutes. That's one. Then usually the patient that has migraine wants to be in a quiet place, no noise, no lights. Photophobia, phonophobia. So patient avoiding lights and noise. While the patient that has cluster headache usually is really very restless, is moving up and down. That's one clear way to distinguish cluster headaches from migraine. Also, they have parasympathetic symptoms. So, for instance, patients with clusters can have myelitis, can have ptosis, can have lacrimotion, which can occur in migraines if like we said, if the salivatory nucleus is affected, but usually not very common. So these are some ways. Then clusters are commoner in males, while migraine is commoner in females. So some of the ways you can distinguish cluster headaches from migraine. Then sexual type headaches, usually patient is able to go about his activity without issues. While for migraine, patient just wants to be in a place. It's actually quite disabling for most patients. Patients are avoiding things that can trigger and then just wants to stay in a place. And then another thing for tension headache is burn-like. But the patient will complain of a burn-like sensation, while in migraine, it's throbbing or pulsating.
Okay, to add to that question, Dr. Just is saying, you mentioned left for cluster and right for migraine. Please, I didn't get that.
I said that cluster headaches are side locked, meaning that the patient has it on a side, it persists on that side every time he has a cluster headache. So if he has it on the right, it would always be on the right. However, for migraines, they're not side locked. Patient can have headaches on the right this episode, and then some other time can have on the left. So it's not side locked. as compared to cluster headache that is side locked.
All right. Well, thank you. Next one. It's clearer. Okay, Dr. Wiki says thanks
Sorry,
for the.
Omoyo, can you please say that again? Sorry, I didn't understand. Sorry, Kele, sorry.
Good morning, Chief. I said cluster headaches is usually side locked. Patient has headache persistently on one side. Every episode, the headache is persistently on one side. While for migraine, it can change. It's not side locked. It can change, move from the left to the right. Though hemicranial, it's not side locked.
Okay, thank you. Thank you. I didn't hear that. Thank you.
Okay, thank you so much, Ma.
Then just to add on, Ikiri, I think cluster headache also has conjunctival injection. They have red eyes as compared to migraine. So I think that's one way to differentiate cluster headache from migraine.
All right. Thank you so much, Dr. Kalabama. Okay, so Dr. Wiki is saying thanks for the excellent presentation. Please, what are the red flag signs that may necessitate investigations in migraine headache?
Now, it's like we said, the migraine is a primary headache. Other things that you might see that you find some secondary headaches are the red flags. And there's a mnemonic SNOOP 10, SNOO, then P10. So the S will stand for systemic symptoms. Patient that has fever, for instance, you think that is past the migraine, there's something else, maybe like meningitis. Then new onset headaches, you want to think of, that's a red flag. Then other patients that are more than 50, you think that that's a red flag. You want to investigate this patient properly. Then another O is patients onset of headache, for instance. Patient has sudden onset headaches for maybe a migraine, for instance, and now says that this time around the headache has changed. This is the worst headache of his life, for instance. So the new onset, you think of it's a red flag. Then the P's, there are 10 of them. Pregnancy and puerperium, a patient with papilledema, post-traumatic headaches, postural patients that have worse headaches or headaches with Valsalva maneuvers. Those are the ones I can remember off on top of my head, but there are 10 of them, 10 P's. So if you see all those signs or symptoms, then you think that it's a primary headache, it's a secondary headache, and then you want to investigate the patients further.
All right, thank you so much. Okay, so Dr. Alozo is saying thank you for the presentation. Dr. Alozo Ugo, did you come across the doses of the medications for treatment of migraine?
Yes, I did. My just first will be okay. So I did, for instance, the one we commonly use. Let me mention sumatriptan, for instance, that we commonly use. Usually, you tell your patient to start with 50 milligrams, and then if between 1.5 hours to 2 hours there's no respite, patients take another juice, and you continue like that, but you don't exceed like 200 milligrams in 24 hours. Then, for instance, commonly used Erenumab, for instance, you can do 70 to 140 milligrams, and it's given subcutaneously every month. So there are different dosing. So I didn't want to bother us with those doses, but there are doses everywhere. Yes, I'll add it to my presentation, one of my slides. Those are the common ones we use.
Okay, thank you. Okay, so Dr. Cassidy Ibe is saying, thank you for the brilliant presentation. In what condition or conditions is or acute treatment of migraine contraindicated?
I don't know of any I don't think it's a contraindication per se. You just treat the medications you. So I mentioned, for instance, if a patient has coronary artery disease, you don't want to give triptan. You can go ahead and give some other drugs that would not cause vasoconstriction. I wouldn't say there are contraindications to treatment of acute migraine, but you would look at the patient holistically. Are there other comorbidities that you don't want to worsen? And then you tweak your drugs according to that. So for instance, like I said, the TANs, like lasmiditan, doesn't cause vasoconstriction. So if a patient that has coronary artery disease, for instance, or peripheral vascular disease, can go ahead and give those patients instead of the regular triptans that we use. So there's no contraindication per se, but to treating the patient with acute headaches.
All right, thank you. Okay. Dr. Adiboka is saying thank you. Dr. Owal Schreiber says thank you for the good presentation. I think cluster headache usually presents with retroorbital pain. Thank you. Okay, thanks for the add-on, Dr. Oh, okay, so Dr. Momodu is saying thanks so much, Chief Balogs. Dr. Raga says excellent presentation. Dr. Asakeme says thank you so much, Dr. Moye. Hemicranial is not restricted to left or right. Migraines could also be solely frontal or solely occipital. Okay, thanks. Then venlafaxine is an SNRI, that's serotonin norepinephrine inhibitor. Kudos. Thanks, Dr. Asakeme. Okay, sorry, serotonin norepinephrine reuptake inhibitor. Okay, thank you so much for the comments. Okay, so there's a hand up. Dr. Adipimpe, please go ahead.
Okay, good morning, facilitators and colleagues. Thank you, Dr. Omoye, for a beautiful presentation. I have just a little comment. So for the treatment of acute treatment, it can be non-pharmacological and pharmacological. So for the non-pharmacological, you actually mentioned them, but you didn't classify. So for the non-pharmacological, rehydration is very important. Some of them you need to use ice pack as an ice element. Then they are counseled to avoid triggers. It's very important as most patients with migraine headache have their triggers, and the triggers can be poor sleep. Some of them, when it's related to their menstruation, stress also. Stress is a major trigger for migraine headache, and they are advised to avoid such triggers. Thank you.
Oh, thank you so much, Dr. Bimpe, for the add-on.
Please, where do you put the ice pack?
On the head, on the head, on the head. The ice pack is like they call it ice pack helmet or ice pack gear. So some of them, once they put the ice pack just surrounding a napkin and they place it on the head, it helps to relieve the headache for some of them. So even though with the non-pharmacological treatment, some of them, when it fails, it might now move to the pharmacological treatment. That's the drug prevention, like the sumatriptan she mentioned.
Thank you.
Okay, thank you so much, Dr. Bimpe. Okay, some of the triggers could be food too, like tea, coffee, chocolates, some beverages. Some people even weather changes. Okay, could also be
Sorry,
triggers.
Dr. Bimpe.
Yeah.
Sorry, Dr.
Go ahead.
Bimpe. I just have a question. Okay, like in migraine treatment, I know we have some for preventive to prevent migraine. So which do we give to prevent the migraine? We have the curative, like the one you give, like it's spot on, and the one you give to prevent attacks from occurring. I don't know. Can you help, please? Thank you.
Okay, thank you. She actually mentioned them. So for the acute treatments is the one she mentioned. Those are the sumatriptan. When the patient is having the headache, immediately you give those drugs to abort the headache, the sumatriptan, the cafegods, the lasmeditans, those and the naproxens, that's the NSAIDs and the likes. So those are for the abortive treatment. But there are some indications for giving preventive treatment, which she mentioned. When a patient is having more than 4 acute headache, when a patient is having more than 4 migraine headache in a month, is an indication for prophylactic. When they are disabling horrors, like hemiplegic horror, some of the brainstem horrors, they are very disabling, so there are indications for giving preventive treatments. Then also presence of, when the patient does not respond to the acute treatment, and when the patient is having complications to the acute treatment, there are indications to start preventive treatment. And the examples of the preventive treatment are the classes she listed: the antidepressants, which is one of them is amitriptyline. Another class is antihypertensives like the propranolol, the candesartan, the lisinopril. Another class of preventive treatment are the anti-epileptics, of which is sodium valproate. So those are the preventive treatment, and there are indications for starting the preventive treatment. Thank you.
Thank you.
All right, thanks so much. Okay, do we have any more? Okay, Dr. Momodu, please go ahead.
Well, thank you so much, Chief Balogun, for the beautiful presentation and the other add-ons. Please, I just have some little concerns. The first is what's your take on the use of opioids and barbiturates in managing a migraine? Can we give them? Then two, I didn't get to hear, can we do some nerve blocks most especially for these migraines that are refractory to all of these treatment. If all this treatment fails, what do we do? Thank you.
Okay, opioids, evidence for opioids is low at best medium, but it's effective for some patients. So you might have to neutralize for those patients, but the evidence for it is actually quite low. So it's not the first line as it were for patients, especially patients that have severe headaches and severe migraines. Then I also mentioned that you can do neuromodulation. Let me go back to that slide. For instance, you can do hospital nerve blocks lidocaine for patients that come acutely. And then some other things can do neuromodulation. I said is the use of impulses, electrical and magnetic impulses to the skin with the aim of altering pain perception and then processing. It's in the slides. If that can be done.
Okay, thank you, Masood. That's like the last resort. So if that still fails, if that still fails, it doesn't fail. I'm just a bit curious because we had some patients who still have this chronic migraine despite all of these treatments.
Also being quick, please help. I'm not sure there's anything else, but that's the bit I saw. Neuromodulation, that's the last resort.
Okay.
Yes,
okay, thank you.
Most neuromodulation doesn't fail. At least with proven evidence that though it's not readily available in this country, but it doesn't fail.
Thank you
and
so
even
much.
Before going to neuromodulation, there are newer drugs like the erenumumab, the CGRP receptor antagonist that she mentioned that is given subcutaneously every month, especially for patients with chronic migraine. Presently in Nigeria, that's still the last resort. And patients are responding quite well, apart from the fact that it's expensive, but it works very well. But presently, neuromodulation is not readily available. But in centers, other parts of the world where it's available, it has not failed. Thank you.
Thank you.
All right, thanks so much, everyone, for your comments and contributions and the questions also. Okay, so I think, okay, Dr. Yahaya is saying, Dr. Taiwo Ode Dodja, opioids and barbiturates should be avoided because of risk of medication overuse headaches. Okay. Chief, do you want to make a comment on that? Hello, Dr. Balogun.
Yes, I agree with him. But like I said, I didn't see any evidence for barbiturates, as in not using barbiturates, but opioids can be used in combination. I saw in continuum, like, can use opioids, but for mild cases and then for for mild cases and then for patients that respond, but not the first line. It's not the first line. Barbiturates, I didn't see any mention of barbiturates for migraines. Then yes, for most patients that you give that has to use acute treatments, there's risk of medication overuse headache, and then you should be wary of that.
Thank you. And then Dr. Yahaya Mohammed is saying, and botulinum toxin can help. Thanks so much, Dr. Yahaya. Okay, so at this point, I'll hand over to our teachers. Christabel.
Oh, thank you so much. Take care. Dr. Balogu, thank you. That was wonderful. That was an excellent presentation. I take it to a neurologist. You sound like one.
Yes, ma'am.
Exactly. You were at home with the topic. You were so fluid. So you spoke like a neurologist. So thank you so much. Thank you. Dr. Adebigbe, thank you so much. Thank you. Thank you. I appreciate you. Dr. Yahaya, the neurologist in the house, thank you. It was quite an elaborate discussion. We appreciate your contributions, your questions. Once again, Dr. Kalamama, Dr. Momudu, Dr. Asekeme. I don't know if I got all the names, but thank you all that contributed. We appreciate your contributions. Dr. Success, I don't know if you have any comments.
Okay, I do. Good morning, teachers, facilitators.
Wait, Dr. Success. Hello. Before you talk.
Okay, sorry, Chief, go ahead.
I want to ask about something. I don't know if it has been thrown away or maybe when I was locked out, I didn't hear it. There's this thing that they used to sing to us then about the pathophysiology. This is it cortical spreading depression about you?
Chief, don't worry, I will address it. It's part of my it's part of what I want to say.
It's okay.
Yes, sir.
Go on, go on.
Okay, can I continue now, Chief?
Yes, you can, please.
Okay, so thank you, Dr. Balogun. That was excellent. And I don't even know where to start from. The things to say are plenty. Okay, so let me start from what the concerns of Momodo. Yeah, I think Pimpi has addressed that. Now, the truth is that we now advocate for use of, calcitonin gene-related peptide, either the antagonist or the antibodies, because we have discovered that these molecules actually help. Okay, because when we talk of the pathophysiology of migraine, okay, so we'll see that they are actually one of the major, neuropeptides that are released. And so if we target them, we are trying to see how, that could be made available. It's available actually, but it's very expensive. I think one shot is like 400K. And then you use, just like she said, use it subcute and once a month. But for those that we actually place on it, it works. Even before the neuromodulation, the CGRP, they rarely fail. And so sometimes when they actually take it for like 2 years, they can actually win them up and these patients do better. But like we said, the money involved. Now, you must address the risk factor, the stressor, the migraine trigger. You must address it in your management. And then, of course, we have talked of the chocolate mnemonic, okay? C for chocolate, cheese, oral contraceptive, caffeine, whether the use or its withdrawal, alcohol, travel, exercise, sex, stress, strenuous activity. So these triggers have to be addressed in the management of migraine. I want to talk, okay, so for patients that have chronic migraine too, botulinum Butos can also use, and it has shown to actually be helpful. Now, addressing the talk on cluster headache. Now, cluster headache too is unique. It can also be very disabling. If you've seen a patient with cluster headache, the patient will even tell you that it's the worst headache of my life. So we need to investigate extensively and then manage. Sometimes it doesn't respond to the conventional, painkillers, and then you just have to go the extra mile. Sometimes we even go ahead to give them steroids. They can be very difficult to treat. So when you see a patient with cluster headache, okay, first of all, it is, cluster is more common in men. Why migraine headaches is common in women, just like she has said, sometimes in a ratio of 3:1. So cluster more common in men. And then, it can last for, it can last between 15 to 180 seconds. And no, so for the diagnosis, the patient needs to have at least 5 headaches, okay, of severe unilateral, temporal, or orbital, or sometimes supraorbital pain, lasting, like I said, 15 to 180 minutes if it is left untreated. And so these patients have restlessness, agitation, and then they also have the autonomic symptoms. Okay, so they can have lacrimation, conjunctival injection, facial, flushes, rhinorrhea, congestion, and then, very important, partial Horner syndrome. So these are the things we see for patients with cluster, just to talk about it and then differentiate, it with migraine headaches that she talked about. Now, for the pathophysiology of migraine headaches, this is very important because even for part 2, they will ask you, what is core, which is actually the first thing that happens in migraine, is the cortical spreading depression. Now, let's see what happens. Let's follow through. Maybe activation from the central generator. The central generator can be anywhere, whether in the brainstem, sometimes in the cortex, okay? And now when this is being activated, it causes release of neurochemicals, okay? And these neurochemicals, one of the most important of them, the neurochemicals, is what now actually causes what this cortical spreading depression. Now, when this cortical spreading depression happens, you will not find out that there is dilatation of the meningeal vessels. And then, if you check her pathophysiology, she talked about the activation of the trigeminal vascular system. This is important because when there's activation of this trigeminal vascular system, it is what causes the release of neuropeptides. One of it, which is very important, is the carcinogen gene-related peptide. Okay, so this is very important. Other ones can be neurokinins, bradykinin, but the most important of this neuropeptide is the carcinogen gene-related peptide. Now, when this is being, released, this is what causes the trouble we see: worsening vasodilatation. There's increased, firing of the, trigeminal afferent, and then this is what we see, and that causes the pain intensification in patients with migraine. This continues, and then you will see, in the diagram, you see areas like the trigeminal nucleus caudalis. Now, what happens is that this afferent, deep pain afferents, have been taken to the trigeminal nucleus of caudalis, and then this is what now sends it to the thalamus. Just like she has said, the thalamus is the center of sensory, and also the relay center. So it is taken to the thalamus. From there, this now gives the continuous, ascending fibers or signals that we see. And then this patient starts having symptoms like photophobia, phonophobia, nausea, vomiting, and then the continuation of this firing will also, cause what she also talked of, which is the central sensitization, allodynia, and then the cycle continues. So this is what actually happens in the pathophysiology. But now we know that there are many theories coming up, many mechanisms coming up, but this is actually the basis. Okay, in patients that have migraine. This is important too, because for those that are going for part 2 neurology, it comes out a lot. Okay, especially this CSD, central spreading depolarization. Let me not talk more than this. Thank you so much. Before Ma will accuse me of giving a sermon. Thank you. So this just happened. Thank you, presenter. Thank you.
Dr. Success, we don't mind sermons. So most important thing is that information is being passed. So we appreciate you. So if you have more to add, please go ahead. We encourage you to preach the gospel of migraine. Thank you so much. Dr. Mahmoud asked you a question, I think so.
Okay, Mamadou, what did you ask?
Talking about which is first, CSD activates the vascular system. You said the reverse, why explain?
Hello, Ma. Sorry, I actually got to hear from you. You said the first thing is the cortical spread depression. Then when you were making mention of the activation of the trigeminal generator, you now say it stimulates CSD again. That's why I kept on, I wanted to just have a clarification, Ma.
Oh, please, can you repeat what you just said? Your line is breaking. Can you please repeat what you just said?
Okay, Ma. You said the very first thing is the cortical spread depression, which we activate the trigeminal system.
That's true.
Yes. But why explain, Ma? You now still said the trigeminal system will secrete, what they call it now? Factors that would
neuropeptides, yes, like the carcinogen
that will upregulate CSD again. That's why I didn't quite get.
Mamadou, I'm trying to understand what you said. But
the neuropeptides, after the activation, the trigeminal neuropeptide secretion.
Yes, so they cause worsening vasodilation and then the increase firing of the trigeminal afferent.
Okay, not back to the CSD.
That intensification of pain we see in migraine, yes.
Okay.
So so activation of the central generator, which now causes CSD, which is the cortical spreading depression. This now causes dilatation of the meningeal blood vessel, and then activation of the trigeminal vascular system. Okay, so this now.
Okay, my confusion has been said again. You said which now causes CSD again. Or is it like it's a recurrent setting?
Which causes activation of the trigeminal vascular system.
Okay. Then
yes, that's what I said. Yeah, so cortical spreading depression causes meningeal blood vasodilatation and then activation of trigeminal vascular system. It is this activation now that causes release of the neuropeptide, such as the PGRP. Yes, that's what I said. Yes, sir.
Thank you so much, man.
Thank you, sir. Thank you.
Thank you. Thank you. Thank you, Dr. Success. I appreciate your contribution. Thank you so much. The presenter, Dr. Balogo, that was wonderful. Everyone that contributed, thank you so much. Dr. Kele, we barely have time for the second question. So I think we should go to the next presentation. Thank you.
All right, thank you so much, Ma.
Thank you.
Okay, Dr. Mosokwe. Hello, Dr. Robo.
Yes, good morning. I'm trying
Okay,
to
please go.
share my slide now, please.
All right.
Are you encountering any problems?
Not really, sir.
Okay, awesome.
Can you see my slide?
I can see
Yes.
it.
Okay. Good morning, colleagues, facilitators, and teachers. I'll be taking practice question 3B. The questions are, what is diabetic ketoacidosis? The second is, how do you make the diagnosis? The third is, what are the current ways of managing it as principles of management? The fourth is, define diabetic foot syndrome. And what are the principles of management of diabetic foot syndrome? So to the answer, diabetic ketoacidosis is a life-threatening hyperglycemic DM emergency characterized by hyperglycemia, ketoacidosis, and ketonuria. Essentially, the second question is about the criteria for diagnosis. So according to the Joint British Diabetes Association, which talked about the DKA, we need all three to be present to make a diagnosis of DKA. Capillary blood glucose of above 11 millimoles per liter, and capillary ketones of 3 millimoles per liter, or urine ketone of 2 pluses or more, and a venous pH less than 7.3, or a bicarbonate less than 15 millimoles per liter. For the sake of the principles of management, one, rehydration, secondly, insulin administration, and then identification of precipitants and removal, and identification of complications and correction of them. I will expand on this later, but I will just speed to the remaining part of the question. Okay, the other question is to define diabetes mellitus foot syndrome. The diabetes mellitus foot syndrome is understood to be all pathologic changes in the foot of a person with diabetes. This would include the pre-ulcerous lesions, such as abnormal corneal callosis up until the ulcer or necrosis stage. So it's a spectrum. And then also we're told to mention the principles of management of diabetic mellitus foot syndrome. One will be metabolic optimization and treatment of the underlying internal disease. The second will be infection control. That is in the case where there is an ulcer present and there are features of infection. And then the third will be debridement of the tissue parts that are not vital again, and effective pressure relief. Sorry, sir. Sorry, sir. I'll go back to those slides, sorry. Then local wound treatment appropriate for the stage of disease and therapy for vascular disease, and then surgical correction of foot deformities and or misalignments, and then patient training. So I'll go to expand a bit on the two arms of the questions, because there are two arms to the question. So I built it around those discussions. So please permit me to go ahead. Sorry, my intention is not to move the slide too fast. Okay, so going back to diabetic ketoacidosis. We've stated what the criteria are and then the principles of management. So I want to expound a bit. According to the guidelines, the treatment of diabetic ketoacidosis should be phased. And within the first 0 to 60 minutes, as the patient is presenting to the emergency, like we said that this is an emergency, patient should have 0.9% saline via wide bore cannula via infusion pump ideally, and then 50 units of IV insulin to be given in 50 mils of 0.9% saline at 0.1 units per kg per hour. We'll continue baseline insulin. That's if the patient was initially on insulin. It is advised that the patient continues baseline insulin at the dose that he or she was being given and then at the time that he or she was being given. And then we make effort to do investigations that are necessary, serum, electrolyte urea creatinine, chest x-ray. Electrolyte urea creatinine may show us electrolyte abnormalities and then may also show us metabolic acidosis, and there may also be derangement of creatinine or urea. And then chest x-ray, especially if we are suspecting that chest infection may be the precipitant of this episode or the diabetic ketoacidosis. Arterial blood gas, majorly to check the pH. Like we said, one of the criteria would be a venous blood pH that is less than 7.3, and then full blood count may show us a septic pattern. ECG, as we know that in them, myocardial infarction can also be a precipitant of diabetic ketoacidosis, and also the features of hyperkalemia that may be seen on ECG. Also urinalysis and then microscopic culture and sensitivity for urine in the case where suspicion is of sepsis from the urinary tract. And then we monitor vital signs regularly. And then ideally, blood sugar should be checked hourly, as well as ketones. And then the potassium level should be checked at 2 hours and then 2 hourly after then. And then the treatment of underlying factors. Because of the nature of presentation, intervention should precede or go pari passu with history and examination, in which case history may show nausea, vomiting, diffuse abdominal pain, anorexia, malaise, rapid weight loss, and then presence of osmotic symptoms. It may also be noticed that the patient who was previously on insulin had missed some of his or her injections, and then features of infection may also be elicited like cough, fever, and then dysuria. Patient may come in confused, and on examination, patients would appear ill, may have dry skin, be in respiratory difficulty, and the mucous membranes may be dry, loss of skin to go, and then decreased reflexes. Patient may also have this acetone or ketotic breath. And patients could come in hypotension and have tachycardia. Now, some of the
Is it just me? Can't hear.
Hello, can you hear me?
Okay, I can hear you.
Okay.
Okay.
Okay, so some of these complications could be present at the time of presentation of the patient, so it would be good to also be on the lookout for them. Patient may have accompanying cerebrovascular disease, may also have myocardial infarction. Patient may present with signs of infection, especially fungal, may have rhinocerebral mucormycosis and other things. Now, these are some of the differences between hyperglycemic hyposmolar state and diabetic ketoacidosis. The major pathophysiology in hyperglycemic hyposmolar state is hypertonicity, while that in DKA is ketoacidosis. So the primary focus in HHS would be controlled rehydration for DKA, yes, rehydration is advocated, but the primary aim is insulin administration. And because their blood sugar may not be as high as we see in hyperglycemic hyposmolar state, we frequently get to steady state, I mean, in terms of serum glucose. So part of the management may need to be glucose administration at some point, depending on how early that is achieved. And then some of the things that I encountered that should be taken note of, electrolyte derangement. In patients with HHS, there is severe elevation in the serum osmolality, usually in excess of 320 in those patients. In patients with DKA, there may be elevation in serum osmolality, but it's usually not as high as in DKA, usually said to be between 300 to 330 in them. So anion gap is calculated, and anion gap is usually increased in them, and that's also part of the things that should be monitored. The time required, well, this is not set in stone, but the time required to achieve results or to get to the endpoint may be as displayed here. And then patients affected are usually type 2 diabetes mellitus patients in HHS and often older, and in patients with DKA, usually younger and type 1 diabetes mellitus patient. Like I said, this is just a rough guide and not set in stone. So in this patient, hello?
You have 1 more minute.
Okay.
Round up.
Okay. So this is just to show the rate of infusion as correction with fluid as is detailed in the guidelines. And then essentially, you should note that there should be more cautious fluid administration in young people, in elderly people too, and then in pregnant women, patients with heart failure and renal failure. And these patients will usually require nursing in the high dependency units and the use of a central line for better control of fluid administration. Now, these are our aims. The rate of fall of ketones of 0.5, at least 0.5 millimoles per liter per hour, or bicarbonate rise of 3 millimoles per liter per hour, and glucose of 3 millimoles per liter per hour is advocated. And then to maintain serum potassium in normal range, avoid hypoglycemia. It is expected that if the serum potassium is less than 5.5 millimoles per liter, there may need to be a correction of potassium. Usually, if it is between 3.5 to 5.5, they say that add 40 millimoles of potassium into the IV fluid. However, if it is much lower, we need to adjust that accordingly. And then this, of course, between the first hour and 6 hours, sorry, I will not be able to go through this. And then at 6 hours, some of the things that are supposed to be monitored as listed, it's important to know that thromboprophylaxis will be of benefit in these patients. And then the aim is for ketonemia and acidosis to resolve within 24 hours and to switch back to subcutaneous insulin in adequately rehydrated patients when DKA resolves, and leave an overlap time of about 30 minutes between the insulin infusion and then the administration of insulin. We must bear in mind that there's an entity called euglycemic DKA, and especially in patients that that are on SGLT2 inhibitors and patients who may have begun treatment from home. Sorry, to just state some things about diabetes mellitus foot syndrome. It may be ischemic, neuropathic, or neuroischemic in nature. And then there are classification systems as detailed here. And then this is just the Megit-Wagner picture to show us some differences that could be noted morphologically in them. The risk factors are as detailed here. You must know that blindness is a risk factor. Duration of diabetes is also a risk factor. Male gender is a risk factor for diabetes mellitus foot syndrome. Sorry, I will not be able to go over the pathophysiology. Other pertinent considerations are to know that this is multidisciplinary in terms of management of this patient. Principles are stated earlier, And we will need to do adequate investigations, which would include Doppler, ultrasound of the foot, a radiograph, especially when the patient has ulcer. We must also check other vital organs to do the serum UUCR lipid profile, amongst other things. Now, there is importance to use medications because sugar control is cardinal to the treatment of diabetic mellitus foot syndrome with secondary prevention and then risk assessment in these patients, and to have good social support. Prognosis in about 50% of patients that have had amputation due to diabetic mellitus foot ulcer, 50% of them will need a contralateral amputation in like 5 years. And then at the time of presence of diabetic mellitus foot syndrome, there must also be effort to look for diseases in other vital organs like the heart, coronary artery diseases, and renal vascular diseases. And then also in this patient, they may be depressed, and they also usually report low health-related quality of life. Sorry, thank you.
All right, thank you so much, Dr. Rogo, for that beautiful presentation, very detailed. Okay, so we take comments and questions from the participants first. Okay, and let's keep the thanks coming on the chats. Okay, so Dr. Mahmoud is saying thank you so much. Leader, sir, can you differentiate between alcoholic ketoacidosis and DKA and then starvation ketosis? Hello, Chief. You want to make a comment on that? Sorry, Dr. Rogo, can you hear me?
Hello?
Can you hear me?
Hello, can you hear me now?
I can hear you. Can you hear me?
Yes, I can hear you.
Okay, so there's some comments on the comments and questions on the chat for you.
Okay.
Okay, so Dr. Mahmoud is saying, please, can you differentiate alcoholic ketoacidosis, DKA, and starvation ketosis?
Okay. Yes, for alcoholic ketoacidosis versus diabetes mellitus diabetic ketoacidosis. Well, one of them is the causes of this in patients with alcoholic ketoacidosis, usually due to patients that have alcohol use disorder, as opposed to patients with diabetic ketoacidosis. And in them, usually also it's because there may not be insulin deficiency as in patients with diabetic ketoacidosis, but because of the use of alcohol and the conversion of the alcohol to its metabolite and the effect of it on the liver, the metabolism of glucose in the liver. As for starvation ketoacidosis, again, is due to the deficiency of glucose in the system of the patients. Usually requires severe starvation or prolonged starvation before these patients have starvation ketoacidosis. As we said, that ketoacidosis will require at least 2 pluses of ketonuria or 3 millimoles of ketonemia for us to be able to say that this is ketosis. But in these patients, is usually due to prolonged starvation in them. But for diabetic ketoacidosis is usually an acute event and usually due to the deficiency of insulin, or either relative or absolute deficiency of insulin in this patient, in which case the liver digests fatty acids in order to provide energy source for the body, since there is relative inability of insulin to get into the cells in the body. I think that's much that I remember. I don't know if there can be contributions toward that. Thank you.
Thank you so much. Please, can you go to the question? Move to the question. Okay. So Dr. Alozie Wugo is saying thank you so much. Dr. Charles Okore is saying thank you for a good presentation. Dr. Brown Ibapiki says starvation and alcoholic won't have hyperglycemia. Okay, thank you so much, Dr. Brown, for that add-on. And then Dr. Joss is saying there's also beta hydroxybutyrate to acetoacetate ratio that differentiates alcohol ketoacidosis from DKA. Well, thank you so much, Dr. Justice, for that add-on. Okay, thank you so much. Thank you so much, everyone, for your comments. Dr. Justice, Dr. Dr. Momodu, thanks everyone for comments and questions. Okay, I can't see any electronic hands up, so in absence of any other comments and questions, I will hand over to our teachers. Ma Christabel.
Oh, thank you. Thank you so much, Dr. Mosope and Dr. Ekele. Thank you. Thank you. I don't know if there are any comments from our teachers. Chief Remigos, Chief Chito, Chief Bansi, Success, Dr. Yahaya, Dr. Dahatu. Any comments? Dr. Fatima Okopi, any comments? Any comments? So thank you. And seeing Dr. Urogo did well. No comment from any of our teachers. So thank you so much. Thank you. I appreciate the time using getting the slides ready and making yourself available. We appreciate